Good evening, colleagues from Sydney, Australia. Thank you for the invitation to speak on the roadmap from the WHO Human Resource Strategies to Improve Newborn Care in Health Facilities in Low and Middle Income Countries. Even before the pandemic, there was a global shortage of nurses, midwives, and, first slide, please. Sorry, hey, can you go back? Thank you so much. Even before the pandemic, there was a global shortage of nurses, midwives, and other healthcare workers. Now even more so. It's estimated that there will be a shortfall of more than 10 million nurses and midwives by 2030. This is such an important topic, and there has already been such discussion on this meeting around strategies and some great examples from countries that they've implemented that seem to be working. I worked on this roadmap with Nancy Boland under the guidance of the wonderful Dr. Nello Lancetto and in collaboration with the WHO Department of Health Workforce. As with all WHO roadmaps and reports, there was expert advice from a large group of stakeholders, a great many of whom are on the call today. Next slide, please. Thank you. In 2018, the Council of International Neonatal Nurses, in collaboration with the Rwandan neonatal nurses and the University of Rwanda, held a highly successful conference, our first African neonatal nurse conference in Kigali. At this meeting, we held focus groups with participants from many countries regarding their challenges around human resources. I think it's essential that neonatal nurses and midwives are integral to all discussions about their workforce challenges and for strategies to improve in countries. At a side meeting to the conference, key organisations, including the WHO, USAID, Save the Children, and many others, all met to discuss the issues around human resources, and this report is a result of that meeting. My colleague Nancy was employed to bring the report together, and we held technical experts meeting in Geneva in 2019 and further online expert consultations in November 2019 and January 2020. As you will see when you read the document, it's been a great collaborative effort. USAID were a great support funding this work, along with the Casey Foundation. Next slide, please. Let me now take you through the roadmap. The purpose was to provide a framework and strategies for countries to transform their policies on human resources for health, with the knowledge and technical and behavioural skills necessary for high quality care by 2030, and to ensure that all newborns survive and thrive. Next slide, please. The vision and goals are clear. We know that there are cost-effective, proven interventions that reduce newborn morbidity and mortality, and that most newborns can survive and thrive if they have access to these high-quality healthcare. Increasingly, births in low and middle-income countries take place in health facilities, and this provides us an opportunity to improve the care of small or sick newborns. Nurses and midwives provide the majority of care to mothers and newborns, and also make up the largest component of the healthcare system. Even before the pandemic, we had global shortages, and this has only been compounded. In addition, there is also a critical shortage, as we've heard, of specialist medical practitioners. These shortages are one of the main factors for the persistently high mortality rates of women and newborns in many countries. We needed to look at the gap in... Sorry, can we mute, please? We needed to look at, maybe we can mute. Thank you. We needed to look at the gaps in human resources for newborn care services in countries, identify opportunities to improve newborn survival and health, and the strategies required to accelerate progress. Thus, this report outlines 10 key strategies, and I'll go through them briefly now. They're logical in order, and countries can adapt to their context, national norms and frameworks for health service delivery and care. Some of the strategies have many interventions listed, and I've mentioned just a few on the slides. Next slide, please. The first three strategies consider national and subnational training options to optimise current cadres, with the fourth strategy a plan for more specialist roles. They're logical in order, starting with pre-service education. And we've heard quite a bit of discussion about pre-service education at the meeting so far. The rationale behind the first strategy, which is to improve and standardise the content, curricula, and development of competence in neonatal care and pre-service programmes for health workers, is that training in neonatal care is often limited within these programmes in nursing, midwifery, and medical education, and that countries should review pre-service education of all cadres to improve the quality of newborn care. Within this first strategy, there are 5 interventions, and I've highlighted 3 on the slide, and they include the standardisation of what is taught in pre-service education, and a requirement and emphasis on topics that are less frequently taught, but really important, such as family-centred and neurodevelopmental care, newborn pain, and a recommendation for collaboration between institutions. Next slide, please. The second strategy moves to current newborn care providers to build their capacity through orientation programs, continuing education, skills training, quality improvement initiatives, and support to maintain and increase competence. This next step is for countries to develop effective, regular, accessible refresher training for all providers of newborn care, thus ensuring that they can remain up to date with changes in contemporary practice. There are 12 suggested interventions, which include having relevant clinical guidelines and standards of care, providing health workers with point-of-care decision tools or job aids, and using competence-based learning methods in short, frequent training courses led by experienced trainers. Next slide, please. The third strategy suggests upgrading existing cadres with additional specialised training in neonatal care, with additional qualifications or certification at undergraduate level. The rationale behind the 5 interventions you can see listed on the slide is that before developing a specialised neonatal nursing postgraduate cadre, countries can offer additional training with commensurate specialist qualification or certification, registration and corresponding accreditation of health workers. It is hoped that this increased competence, responsibility and recognition will result in higher salaries, job satisfaction and improved retention. Next slide, please. And the fourth strategy is to create and train a new cadre of specialised neonatal nurses, such that we have in high-income countries. Countries that provide tertiary level neonatal intensive care could take this step according to their needs, resources, and the policies environments to sustain such a cadre. Creation of this will provide highly skilled neonatal nurses. While more costly than non-specialised neonatal nurses, cadres, university degrees might make it more attractive and might result in the possibility of better salaries, career options, and perhaps less staff turnover. Having a career pathway for neonatal nurses is important. The Council of International Neonatal Nurses is working with countries and colleagues on this call today to support the development of curriculum for this new cadre at university level. This strategy has 8 key interventions which countries can consider. An example of 4.8, considering a direct entry degree programme for neonatal nurses, Morocco has already created a direct entry 3-year bachelor degree in neonatal nursing, which has been recognised by the Ministry of Health and Civil Service. And it is important to have the recognition from the ministries of any courses. Next slide, please. We now move with the next 5 strategies to focus on national and subnational actions for the provision of neonatal care. There is strong evidence that regionalisation of maternal and newborn care through networks of health facilities, which are organised by population size and needs with appropriate resources and personnel, and with referral of high-risk patients to higher level care, this improves outcomes. There are 9 interventions within Strategy 5, standardising the levels of neonatal care provision and ensuring safe referral of mothers and infants, and focusing on strengthening healthcare systems and regionalised access to neonatal intensive care while supported by a strong referral system. Next slide, please. The 6th strategy is to establish strategies for health worker recruitment, well-being, motivation and retention. And this is something that is being considered all over the world, in all countries with these global shortages. It is something we've talked about just recently in our neonatal intensive care unit that I work in Sydney. The well-being and motivation of healthcare workers are essential determinants of performance and the quality of care they provide, and also of retention of staff. The 8 interventions include ensuring fair salaries, salary incentives paid consistently that we've heard of today in this meeting from countries with their interventions, ensuring a manageable workload and working conditions. Ratios has come up consistently and workload as a key reason that staff leave, with adequate facilities and a decent working environment. Of particular relevance at the moment is ensuring the provision of occupational health and safety, including protective equipment. Next slide, please. Strategy 7 is ensuring effective staff ratios and skill mixes in local neonatal units, and there is much evidence to support the impact of ratios and skill mix on neonatal outcomes. Staffing a neonatal unit safely is challenging, and the requirements for nursing staff depend on the workload, the skill mix of the staff involved, and the time estimated to care for each patient. They're also dependent on patient needs and the context, level of care, and organisation of care in a unit or facility. This strategy has 13 suggested interventions around determining workload, supporting staff, and very much we've heard in this meeting, advocating for the non-rotation of specialised staff to other units and establishing clear scope of practices. Next slide, please. Strengthening national human resources planning, policy and regulation for the development and management of neonatal services is essential, and at all levels, with 10 interventions in this strategy which advocate for health service strengthening and improving data collection and analysis. Within the 10 interventions and the rationales behind them is that comprehensive national or subnational plans for extending maternal and newborn health services should be based on evidence that includes the quality of care and patient outcomes, and plans should be costed, financed, implemented, and continually revised. Data is key. Next slide, please. Strategy 9 is investment in neonatal health, and investment is so essential. We have to allocate adequate funds for capacity building and support for neonatal care in national budgets. The 4 interventions listed in the slide provide suggestions for countries to invest in trainers and in infrastructure. Next slide, please. Strategy 10 is the final strategy, and this is to promote global strategies, collaborations, accountability, leadership and governance for human resources for neonatal care, integrating innovative multi-country research and learning networks. Human resources for neonatal units should be included in global and national policies, as it's been shown that the survival of preterm infants in facilities in high-income countries is associated with a high ratio of neonatal nurse to infant, the number of neonatal nurses working per shift, and the levels of specialist education and experience of the nurses and midwives delivering care. The 9 interventions advocate for HRH at a global level, and 10.6, as you can see on the slide, is supporting the creation and strengthening of local and national professional organisations and partnering with international groups such as the Council of International Neonatal Nurses and FIGO, as well as many others. At COIN, we are working with countries to develop national neonatal nursing organisations, and we launched the Rwandan neonatal nurses in 2018 and the Kenyan neonatal nurses at our conference in 2019. The involvement of interdisciplinary collaboration with professional organisations and knowledge sharing at relevant global events should be facilitated. Next slide, please. In the roadmap are examples of education programs and career options for nurses and midwives working with newborns, as well as learning and support options for workers in neonatal health in low and middle income countries. And there are examples of successful implementation within countries, which others can learn from. The report has a suggested timeline for action, as you can see, in 3 sections up to 2030, with suggested priorities split into the 3 stages. Next slide, please. To improve the outcomes for small or sick newborns and their families, the importance of the strategies and interventions within this roadmap will be really helpful. It will be impossible to implement any of the strategies that we discuss at this meeting to decrease mortality and morbidity if we do not have sufficient healthcare workers and healthcare workers with neonatal specific knowledge and skills. It is so important now that we advocate for collaboration, investment and strengthening of our healthcare workforce. And I've gone through this report quite quickly. I would suggest to people to read the report because it's really gives really some great ideas for countries to use. I look forward to this important discussion that we're going to have now. And we could have a whole meeting on human resources for health strategies. It is such an important topic. Thank you all for your time.
Thank you very much, Karen, for that very nice summary of the report and touching on this most important topic of human resources. We will have a quick few minutes for questions. Can I call on my colleague, Karen Edmund, to please see if for these 2 presentations, what are the main questions that are coming up that you can pose for Dr. Harish Chalani and Karen Walker. So Karen, over to you.
Thanks, Rajiv. So far in the chat, nothing for Karen Walker. So for Dr. Harish, I will now just look at our list and really start from the start. There was a question about whether immediate KMC in premature babies less than 28 weeks gestation was implemented in the study that you presented yesterday. Please, Dr. Harish, if you're on the line.
Yeah. So, in fact, our inclusion criteria were the birth weight, which was 1 to 1.8 kg. And in fact, when we looked the data, it was below 31 and 31 to 34, and then beyond that up to 37 weeks. But babies, in fact, below 28 weeks were very, very few, and to look at that data. But our inclusion criteria were certainly above that gestation.
Thank you. Any other 2 or 3 key questions? Could we please mute our phones if we are not speaking? Thank you.
So Dr. Harish, there's also a question about the workload for the nurses. If there was a double workload for nurses caring for both the mother and the baby, and how that impacted on global prioritization for specialized neonatal nursing.
Yeah. So, Karen, actually, it's true that when we have the 12-bedded unit, so there will be additional 12 mothers. But we were keeping those mothers who were not sick, actually, and they were requiring routine postnatal care of the mother. Sick mothers, they used to be in the high dependency unit. So, and if we look at the quantum of the work which has been taken care now by the mother herself, the expression of the milk, changing the diaper. So that work of the nursing force was much less. But yes, there will be some component of the care which was, required to be done by the neonatal nurses for the postnatal care. But overall, we found that the nursing personnel, they were quite well satisfied with the mothers being there in the unit.
Okay, last question for Dr. Chelani. So you
There
can
was a
choose a
question
priority
about,
question.
sorry, Rajiv?
Choose a priority question because of time.
Yeah, there's a question there's been a couple of questions about financing. I suppose both from the user perspective, from the family perspective, as well as the health system. And if the families encountered a particular user fees, and also how the health system in the studies financed the program. Thank you, Dr. Harish.
So I think the initial infrastructure was, of course, built with the support of the administration, and the cost is involved. But if we look at the finance purpose or from the insurance purpose, because that was also the question which was linked actually. So one has to design the insurance system in such a way that it covers the mother and baby diet together, rather than the baby alone, because it is a mother baby diet together. So I would say that the cost would be of the infrastructure, and in any case, mother had been staying in the postnatal ward. So it is the redesigning of the new units which we are going to make it. That mother's bed has now been shifted inside the unit, so making it together.
Yeah, I would like to add to that there was this question about for the study, how was it done? I think for all the infrastructure changes, it was the hospital itself which paid for the changes. And we did a cost and cost effectiveness very preliminary analysis. And it is really surprising that if you really do look at the cost of in the infrastructure change over a period of 10 years, it is actually really so cost effective if it comes to life saved that one should not even hesitate to think about it. But we are doing a formal cost effectiveness analysis of all the countries that participated. So thank you very much, Dr. Chelani, for answering those questions. If you could have 2 or 3 questions for Karen coming from the chat box. I don't know if someone, Olive or Karen, if you have been looking at that.
Yeah, no, Rajiv, I can, so there's been a number of questions.
I can't hear you anymore, Karen.
Yeah, can you hear me now? How's that?
Yes.
Yeah, thank you. So the question for Karen Walker, what is the role of performance-based incentives in neonatal care? So are there particular strategies within the roadmap itself, or other performance-based incentives that you'd like to address? Thank you, Karen.
Thank you for that. Can you hear me okay?
I don't know why I'm getting Spanish or some translation. My channel is English. I don't know. This is the first time I heard that. Thank you.
But we are able to hear her, so I think the question can directly go to the speaker.
Yeah, please go ahead.
Can you hear me okay?
Yes.
Yep. Oh, great. Performance-based incentives is not something that we're used to in high-income countries, but it was suggested in the roadmap that it's an intervention that could be used to encourage nurses to stay within units and to mostly to just think about this one. To stay within the units, to provide more care and to learn and attend more courses. I think it's not something that I've been very much familiar with, but it was good to hear that this has actually been discussed in some other countries, and perhaps some others with more experience in that could give us some examples in the discussion of how they've actually done this. Thank you.
Thanks, Rajiv. So another question for yourself, Karen, is what you recommend as ways to promote non-rotation, and what you think are the options. So this is actually a separate question. What do you think are the options for on-the-job accreditation for neonatal nurses? So the first question is, what do you recommend in the ways to promote non-rotation of staff, if indeed you feel that's a preferable approach? Thank you, Karen.
I think non-rotation of staff is a really important aspect. If you train your neonatal nurses and midwives to have specialized skills, and some hospitals rotate them in a general, that's their practice, is to rotate them around the hospital, then you lose these highly skilled nurses and ones that you've invested in with training. So this is something that needs to be done at a hospital level and could be done at a national level. Obviously, and even in high-income countries, we have redeployment of staff to other areas, and that's certainly happened in the pandemic. But if you can have strategies where neonatal nurses who are used to looking after the smallest and sick of newborns, and they've got highly specialized skills, to not move them to look after adults and others in the hospitals. So it needs to come from a hospital policy and perhaps even a national policy. But it's an area to actually prevent staff rotation and to keep the skills within where we need them with a small and sick newborn. I think the second question was on the job training. And there are different aspects, as the roadmap has guided you through, on different aspects of training. And one of them would be on the job training with short courses and accreditations. And the Council of International Neonatal Nurses have published competencies which could be useful for countries to use with skills checklists to do on the job training. And many countries and many neonatal units have clinical nurse educators and nurse educators within the units who can facilitate on the job training. And I think it is really important.
Thank you very much, Karen and Karen, both of you, particularly Karen Walker, for that nice presentation and answering the key questions. I'd like to quickly move on to the next session and hand over to my colleague, Ted Bab.
Okay, thank you. Thank you, Rajiv, and thank you, colleagues. Welcome on this, the last day of this exciting session. So in the coming, in this session, we have a very interesting presentation, and look forward also for the lively interaction and participation from you. We will be hearing, presentations on innovations by two esteemed colleagues, Professor Rebecca, who is a professor of bioengineering from Rice University and a co-PI of the NEST program, and from Dr. Adriana, who is the group lead for medical devices in WHO. So they will be presenting on medical innovations, equipment innovations to address the smallest sick newborn. This would be followed by a presentation by Kristen from the PATH, who she is leading the Maternal Newborn Global Program and Child Health Global Program, and she is Associate Professor at the Global Health at the University of Washington. And the last presentation would be by Professor Susan from Colorado University, who is a neonatologist. She will be presenting on the developmentally supportive interventions. So over to Rebecca for the first presentation, who will be followed by Adriana.
Thank you so much. Can you hear me okay?
Maybe a little bit louder, thanks. Rebecca.
And can you see my slides okay?
Yes, we do. Yeah.
Excellent. Well, thank you so much for the opportunity to share some thoughts about the role that innovation can play in achieving quality care for small and sick newborns. I'm presenting today on behalf of the NEST team, which is working in 4 countries in Africa, Malawi, Kenya, Tanzania, and Nigeria, to deliver a bundle of technologies as part of a health systems package to provide life-saving small and sick newborn care. I think we all recognize that innovation is one component of quality small and sick newborn care, but it is a critical component. And technologies can't help babies if they are broken and living in an equipment graveyard. I sometimes wish that all medical devices came with a warning label that said this medical device can only save lives if it is used. And I think innovation can play 2 very important roles to help us improve care for small and sick babies. The first is to help us deliver a bundle of rugged, affordable, high quality technologies. And this really means 3 things. Technologies have to be available, they have to be used well, and they have to be maintained. And we can't just think about today, we have to think about the future. How do we develop and manufacture the next generation of technologies? And how do we empower African inventors to develop technologies to address needs in their own hospitals and make sure that they are part of global collaborations to develop the next generation of technologies? So in the time that I have, I'd like to walk through each of these steps. And I'd like to start with delivering a bundle of technologies. How do we make sure that the right devices are available? UNICEF and NEST worked together with the global community. We brought together hundreds of engineers and clinicians to develop a set of target product profiles. What are the criteria that effective, affordable, rugged technologies should meet across a wide variety of product categories, and these are now publicly available. The NEST team worked to evaluate commercially available technologies to determine whether or not they met the TPPs. We looked at technical specifications, conducted extensive environmental testing, as well as usability testing across a variety of settings to make sure that tools were easy to use by the target users. And commercially available devices which met those criteria, we deemed as NEST qualified technologies with multiple devices in each product category. And to help local distributors be sure that they had access to these affordable, effective technologies, a new global nonprofit, Hatch Technologies, was formed to help make the bundle available to local distributors. And in addition, important feedback was provided to manufacturers about how to strengthen the performance of their technologies so that they're easier to use and can last longer in harsh environments. What did it cost to do this? NEST supplied this bundle of technologies to 65 hospitals across 4 different countries. And we went in and did a health facility assessment to look at how many functional technologies were available across the product categories that are listed here. And then we added the additional numbers of devices that were needed. So for respiratory support, for warming, for and importantly, surge suppressors, spare parts, and repair tools. You can see the cost per bed to set up these fully equipped newborn units is about $1,000. You can see it's a little bit higher in Nigeria, and this points to pandemic challenges. The equipment was ordered at the height of the pandemic when oxygen-related equipment became much more expensive and shipping became much more expensive. So there are fluctuations to be aware of. How do we ensure that devices are used well? We worked with Ministries of Health and the pre-service training institutions And there were great guidelines and standards of care, but there was a big gap for hands-on educational materials. And so a global team developed a set now of freely available clinical education modules that focus on hands-on use of these technologies. And they've been incorporated in national standards and in pre-service training curricula. In-service training programs that brought together biomed techs and clinicians were conducted with the ministry, and then pre-service skills labs were equipped at nursing training institutions so that every graduate had access to hands-on use of these technologies. And a real-time monitor was developed that plugs into the back of any device that is powered from mains power. It uses a simple wireless protocol and cellular data to report in real time when technologies are used, so that if they're not used, immediately distributors can go in and repair or move devices to locations where they will be more well utilized. To ensure that devices are maintained, a similar set of hands-on technical modules were developed with Ministries of Health. Those are now being incorporated into national standards and into pre-service training curricula with similar skills labs equipped. And distributors are now equipped with dashboards that report on real-time performance of devices that have allowed the team to maintain more than 98% uptime with a response time of less than 48 hours to address broken devices. It's so important to empower the next generation of inventors, and one of the most exciting things that has happened over the last 5 years is the formation of a network of African universities that are committed to invention education, that have equipped hands-on design studios and are connecting young inventors to problem owners in hospitals so that they can develop technologies to address those needs. And we really saw the power of these young inventors come to life during the pandemic when inventors in Tanzania and Malawi developed technologies to help clinicians deal with the pandemic, including PPE, which was purchased by UNDP, as well as hand washing stations and respiratory care equipment. And I think these global networks can be a very exciting part of product development to deliver new technologies, for example, point of care bilirubinometry done with low cost, and a continuous temperature monitor that has zero consumables, which will soon be launched as part of this global invention network. So I know I had a very short amount of time today to share with you a lot of exciting opportunities for innovation to contribute to improving small and sick newborn care, but I've highlighted where you can find more resources in terms of the NEST UNICEF implementation toolkit. All of the educational resources, including videos, which are available for modification and free use under a Creative Commons license. The Invention Education Toolkit, which provides universities with resources about how to start and grow invention education programs. And coming soon, a set of device planning and costing tools that we're very excited to get feedback on. So let me thank all of my collaborators and also the organizers for this opportunity to present this morning. Thank you.
Thank you, Rebecca. So Adriana, the floor is yours.
Thank you very much. My name is Adriana Velasquez from WHO, and I would like to emphasize, continuing what Rebecca said, is that small and newborn babies need medical devices for diagnostic and treatment, and they have to be, first of all, safe, good quality, and then affordable, available, accessible, acceptable. So as you all know, to cover the universal health coverage, and you were just talking about financing, so we really need to have the healthcare workforce, and the technology has to help the health workforce. We need to have guidelines, we need to have the health technologies, we need to have information, medicines, and infrastructure. And if these things are not available, then the service cannot be given. So we need to cost it, and we need to define what is the population that will be getting it. So as you all know, medical devices is everything that has not a pharmacological action, and we go everywhere from single use to complex devices. But this is the medical, this is the roadmap that we have in WHO that talks about innovation, exactly what Rebecca was talking about. That is from the industry or academia. And then we do a health technology assessment to try to define which are the list of essential or priority medical devices that have to be in the national list, so that then they can be in the NICU or anywhere else. We have to have the regulatory process to approve those items. We have to have the technical specifications to procure them, do the installation, the training, as Rebecca was saying, so important, maintenance of the conversations that I heard yesterday, the operation, and then doing post-market surveillance, and finally the commissioning. And WHO has guidance for all these processes, and we are ensuring now that we're working towards having a harmonized nomenclature so that we all can know, call the products by their name. WHO has been developing, all these are for process, books on donations, on maintenance and safe use, but also book on human resources for medical devices. That is the role of the biomedical engineers, and the list of priority medical devices. And this yellow one is for reproductive, maternal, newborn, and childcare. So concerning the biomedical engineering, something that was mentioned is the importance, but I would really like to emphasize it is not only on the maintenance, but they are also the ones that could train the nurses for the best use or whatever is needed, and also participate in the planning. And we have many more biomedical engineers coming out from schools as years go by. So the WHO has this list of priority medical devices and essential in vitro diagnostics, but also is been developing these technical specifications so that we can purchase appropriately what is needed. All the books are now hosted in Medevis. This is a new platform that started just this year that brings all the books together with a methodology. And I just want to show you an example here. When I do the filters and I put second referral level, ICU, neonatal, that is what it gives me. From bags, blood glucose, bracelets, catheters, incubators, etc. And then you can drill down in one of them, for example, incubator. Then it says what are the priority, in which book it was, what interventions, which service delivery platforms you need them, what requirements for electricity, gases, etc. And then it even goes to the healthcare settings, the regulatory approvals that are needed, and links to guidelines that are in WHO. And some of them, they even have the guidance, the link to the table for the procurement, so that these are coming from the books. We want to emphasize always when we talk about procurement, about the iceberg concept, in which we have to make sure that the managers don't see just the tip of the iceberg, but everything below, an installation, consumables, and operating costs. We do the same thing for in vitro diagnostics, because they have to go either a lab or not lab. We have also our portals. And if you can see here, I just took this example, is, for example, the exams for TSH to screen for hypothyroidism for newborns. That is all there with all the assessments and information. The idea is that then countries can take these lists, the WHO model list, they can compare it with their needs and epidemiology and resources, and then define their national priority list. And then this list should be able to be procured. Who has to sit around this selection committee? Exactly the neonatologists, the hospital services, the nursing services, the financing to pay for it, insurance benefit package to ensure that it is there, and the biomedical engineer. We made a global survey to try to find out which countries have a national medical devices list for procurement and so. And we need to ensure that list for all the devices required in an ICU should be included. These are coming in the global atlas of medical devices. And then we take this information from MEDEVIS or from the EEDL, and then we now give it to the Universal Health Coverage Compendium. We will be presenting this in the UHC day 10th of December, and then forward to really go into the different needs. Talking about innovation also, because those are for traditional and normal available technologies, but talking about innovation, WHO has been calling in the Compendium for Innovative Technologies for Low Resource Settings. The assessments that we do is very strict, regulation, HTA, HTM, intellectual property, and these are the ones that were released this year. We have here a ventilator, but here you can see all the aspects that we asked for: regulatory assessment, but legal, social, ethical, affordability, local production, ease of cleaning, ease of maintenance. And this is another example. This is a heart rate monitor. Sorry, this is my alarm to say that we're almost done. And the conclusions is WHO has developed a list of medical devices based in evidence by interventions or clinical settings. They include the technical specifications and even information about regulation. They are available for countries to develop or update. The role of the biomedical engineers is to support everything from planning to use. We need a harmonized nomenclature for all medical devices process, and much more work needs to be done for ICU. With that, I thank you very much for inviting me to this important meeting. Thank you.
Thank you so much, Adriana. And then now we'll go to Christian to present on the human milk for small and sick newborn.
Hi, thank you so much. Yes, I am very grateful to be here today and talk about lactation support and human milk making. I think a better way to phrase this is thinking about how do we collectively, as this group thinking forward, develop systems that ensure equitable access to human milk? How do we actually optimize systems that can support that? Next slide. A first question really is to ask, what do we know? How are small and sick newborns fed around the world? How are their mothers supported? And it's somewhat shocking to realize that we don't have numbers. There is no quantifiable number or data that shows us really what percentage of these babies truly have access to their mother's milk, what percentage of their diet is mother's own milk versus formula, sometimes another mother's milk that's been borrowed from the ward. What are the early maternal lactation practices? How many of these mothers are actually supported to start expressing breast milk? We know that they face significant challenges in those first hours. What specialized support is provided to them? Is there even skilled lactation support available? So what we know, obviously, is there are inequities that face families of small and sick newborns. Where really should our priorities be placed? I have this graphic here that is from the Survive and Thrive, where it calls to use data for action, but I would suggest that what we need first is to collect data for action. We really need to be able to quantify these important issues. Next slide. And I like this image because, you know, the question really is, well, why? Why are we sitting here thinking about advancing care for small and sick newborns, and yet something almost so basic as feeding is left unknown? And really, I would suggest that based on you know, work in the field, it's this image that we have newborn care almost on one side of the field and nutrition, feeding, lactation support on the other. And often they simply don't meet. And that has resulted in policy gaps, implementation gaps, and leaving this major issue for small and sick newborns in patient care that we're facing now. Next slide. This is something that we uncovered. We have a initiative called the Asset Tracker, where we're trying to track a number of maternal newborn child health interventions across a pathway of milestones. How is it that they can achieve effective coverage? One of the assets that we explored was the feeding of small and sick newborns. And within doing that, we did find that despite, you know, there is global momentum to improve the quality of care, what we know is that inclusion of feeding as a key component within that care is lacking. We need data, we need appropriate implementation models and operational standards. And something that, you know, is important maybe for this group to stop and think about is, what about if we consider feeding, access to human milk, as almost the link across a number of agendas? How do we achieve IKMC or KMC, nurturing care, respectful maternal care? If we think about provision of human milk as an overarching indicator, that actually could be interesting and help to support further movement in this area. Next slide. So we have amazing guidance in the new standards. There's new BFHI initiatives for small and sick newborns. The issue is we have a lot of guidance that tells us what to do. What we don't have is details around how. How do we truly optimize nutrition for this population? We need policy and attention around how systems changes can occur. There are absolute infrastructure and staffing challenges that do not allow mothers to have this kind of support. We need country-led innovation. And this image I like because we have amazing, amazing initiatives on both sides of the spectrum between newborn and nutrition. Slowly, slowly, we're seeing some of these groups come together, but really what we need is more really focused and pushed integration and collaboration to meet in the middle. Next slide. So specifically, and this probably won't be a surprise to most people on this call, the newborn feeding challenges that face this specific population. One very real challenge is specialized lactation support is very much lacking in low middle income countries where small and sick newborns have the greatest burden. This map is of IBCLCs around the world. The highest numbers are in high income countries. There is a massive gap. So when we think about staffing, capacity building, we really do need to focus on this and improving this cadre around the world with specific focus on the small and sick newborn. Next slide. This call to action was published really trying to delineate what can we do to achieve specialized lactation support in this particular population. And again, there are things that can be done now, and then there are others that require resources. Looking at policies, how can we strengthen those? How can we improve the Nicu training that we have now? In the neonatal ward, are your nurses, how much lactation support training have they had? Do they understand the special needs? And then thinking forward for this group, how do we optimize that environment? What do we do to think forward around supplies, infrastructure, supporting this system? Next slide. Really what we need, and if you can take away anything from this talk, it's this graphic, that what we'd like to achieve is an exclusive human milk diet. That is not to say that at times fortification and other things are needed, of course. But if we can try to promote an exclusive human milk diet, it's a multi-pronged approach with lactation support, the KMC aspects, and then provision of donor human milk when it's needed. Next slide. So human milk banking, for those of you who may not be aware, it's very similar to a blood bank in that it's a quality controlled system to recruit donor mothers for human milk to provide to infants in need. This requires a quality control mechanism. It requires locally appropriate and ethically mandated procedures. And really what it needs is a systematic approach so that we have country-led leadership here. Human milk banking is somewhat new to the low middle income settings. And in order for it to be sustainable, it needs to be integrated with larger programming. Next slide. It is critical as teams are thinking of establishing milk banking or integrating into their system that ultimately we need to understand that appropriate use must be prioritized. Donor human milk, if overused, can do harm. And not every hospital needs a human milk bank. Donor human milk should only be used as a bridge to exclusive direct feeding. It is not comparable to mother's own milk. It should, and in alignment with WHO and other standards, should be used as a replacement to formula. When can you offset formula and use donor human milk? That's really the goal, as a bridge while we're supporting the mother to achieve direct breastfeeding. Next slide. But really, if you look at a map of human milk banks around the world, again, massive inequities. There's about 700 milk banks in the world today, some in middle income countries, Brazil, for one, standing out as a major example. South Africa has quite a number. But if you look at the African continent, if you look at India, who also has many milk banks, there's not sufficient access to donor human milk. So why is that? One major challenge has been that there has not been global guidelines on the safety, on the ethical use, on the clinical use of human milk banking. And that's been a major deterrent to governments. If there is not standards to abide by, how do you begin setting up a system when no one in your country has maybe even seen a human milk bank? Thankfully, WHO is planning guidelines development for 2022 and 2023, and that will be an amazing achievement. One thing that we have done is worked with governments and local stakeholders in a very careful, systematic, phased approach to establish a milk bank, where really ultimately it's about ownership and locally appropriate systems, so you have safety and quality and sustainability. Next slide. And just quickly to walk through an example of this is in Kenya, where we really focused on building a foundation, engaging stakeholders, ministry leadership, developing local guidelines and standards, standard operating procedures that fit within the Kenya context. Next slide. Long before launching, going through multiple trainings, learning exchanges to other countries and settings with integrated human milk banks so that it's very much a part of breastfeeding promotion, then leading up to launching the region's first milk bank. Next slide. And then moving forward to stabilization and thinking about evaluation and regulatory support. Really, a vision here is to develop a regional approach so that can we somehow come up with standards, regulatory guidance, resources in regions. The ASEAN region has done this. Could we set up something in other regions where we have a cost-effective mechanism for establishing these new milk banks? Next slide. And we have amazing resources that have been developed with global stakeholders to really walk through what are the requirements, what are the tools and guidance documents needed to establishing a safe integrated human milk bank system. Next slide. But what I really want this talk to end with is, as we think about developing this generic model, we need to ensure that nutrition somehow is a core component, but it's not just saying that a milk bank needs to be a part of this system. It's really thinking through the package of care that is needed to focus on providing optimal newborn nutrition. Next slide. I'll go through these very, very quickly, and these slides will be available. Really, we need to assess readiness. What is it along the pathway? If you look at the flow of the milk, what's happening from the time the mother has delivered to the time she's discharged? Where is her milk? What can we do to ensure mother's own milk is available? How do we make sure a facility is ready? How do we make sure that their infrastructure is in place? Just thinking about optimizing mother's own milk before even moving ahead to thinking about a human milk bank. Next slide. Curriculum development is very much lacking when we think of specific neonatal lactation support. We need specific training that's feasible and appropriate to the current staffing situation. Next slide. And of course, the accompanying training and capacity, making sure that your staff understand the critical need for this lactation support. Next slide. Quality improvement, we mentioned already the data lacking. We need auditing. We need some kind of mechanism to understand how feeding is taking place and how we're improving it. Next slide. And cross-learning, so critical to make sure that we learn from each other. And again, the regional approach is a cost-effective way to do this. Next slide. And evaluation. Next slide. I want to pause here on innovation, because as we think about advancing something like a human milk bank, that's complex. in low middle income countries, how do you establish a safe human milk bank? And I would say, you know, we also need to support innovation. There needs to be country-led innovation. Why is it, for example, pasteurization is needed for donor human milk? We need locally developed, locally manufactured pasteurizers that are accessible. Speaking, you know, following the Nest 360 team, focusing on making sure we have effective and functional systems. But why is it that we have not invested in this? We would say that everything along the route here presented really needs innovation to make it simplified, lower cost, and feasible. Next slide. And just to close, as we again are thinking about this generic model, feeding of the small and sick newborn has to be considered as a key component. We need to think about the specific and specialized needs. We need very targeted interventions, and we need country-led innovation to make sure that it's context appropriate and sustainable. And with that, I'll say thank you.
Thank you so much, Kristen, for that rich presentation on a relatively neglected area in the care of a small and sick newborn. So the chat box is really active. We will come back to that. So now we'll move to another, you know, silent burden that is less spoken of, and that would be on maternal mental health. For this one, my apology, I didn't introduce Shannon earlier. So Shannon will give a presentation. She is a public health professional in a maternal newborn child health, and she has focused on respectful maternity care, health system strengthening, and implementation science. She has spent her last year working on the Momentum Country Global Leadership Team on maternal mental health portfolio. Shannon, the floor is yours.
Thank you, Ted Bob. Can you hear me?
Yes, yes, we do.
Yes, great, thanks. And good evening, everyone from Bangkok. Thank you very much for the opportunity to speak today on maternal mental health. It's been a pleasure to join the conversation for the last 2 days. So I'm going to share higher level findings from a landscape analysis on common perinatal mental disorders in low and middle income countries that I had the privilege of leading with the Momentum Country and Global Leadership Team. Our landscape analysis looked at the prevalence, risk factors, relationships between perinatal mental health and newborn and child outcomes, promising interventions, implementation strategies, and some gaps in the literature. But today I'm going to zone in on some of the findings that are explicitly related and relevant to the conversation around newborns and, when possible, when the data permits, small and sick newborns. So to give a sense of the depth and the breadth of our landscape analysis, I just wanted to briefly share the methodology that we used. We used a multi-tiered approach to allow for a broad understanding of the current state of perinatal mental health in low and middle income countries. Our first and most substantial lift was a scoping review, which really allows for a mapping of the current state of the literature, determining what gaps are there and will require additional research. But this approach doesn't exclude documents based on the quality of their design or strength of the evidence. It has the advantage of pulling together research, but also all other types of literature, project reports, guidance, guidelines, opinion pieces. We ultimately reviewed over 400 articles. The second tier included qualitative data collection. We conducted a total of 60 key informant interviews and 2 focus group discussions with experts in a variety of fields that play a role in perinatal mental health. And lastly, we conducted a policy analysis of 19 countries to assess what mental health policies existed and how detailed or not they were in regards to explicitly mentioning maternal mental health. So for the purpose of our landscape analysis, we looked specifically at what I'm referring to as common perinatal mental disorders, or CPMDs. These typically include depression, anxiety, somatic disorders, physical manifestations. There are other mental health conditions such as bipolar, psychosis, but for the purpose of our discussion in the landscape analysis, we focused in on the most prevalent, which fall under the CPMDs. So the impact on women's health during the perinatal period of having and experiencing the CPMD are significant. You can see women are less likely to attend ANC, PNC, experience obstetric complications, have preterm birth, practice self-harm, commit suicide, engage in unhealthy behaviors, and are often very likely to be stigmatized and ostracized by their community where they need the support most. So how prevalent are CPMDs? So the data varies, as there are dozens of tools that are being used with different cutoffs and definitions, and we'll get into that a little bit later. But it's safe to say in low and middle income countries, roughly 1 in 5 women suffer postnatally as compared to 13% in high income countries. Like most other health outcomes that we've heard a lot about in the last 2 days, there are gross inequities in prevalence and access to care. There are some studies in specific countries and communities that have been done to show much higher rates of CPMDs. And when we look at vulnerable populations, such as adolescents, women in the humanitarian settings, and mothers of small and sick newborns, the rates get higher. Up to 20% of women experiencing CPMDs have either had suicidal thoughts or undertake acts of self-harm. And the data continues to come out during our current COVID-19 pandemic, showing dramatic spikes in the rates of depression and anxiety. So there are an overwhelming number of risk factors, and many that reach far beyond the health sector, such as poverty, food insecurity, and gender-based violence. But one factor that's important to note here for this audience is that having a smaller sick newborn and traumatic birth is a risk factor for CPMDs. So women having small and sick newborns have been shown to have increased levels of anxiety and depression. The data coming out related to COVID, which I'll speak to in a minute, have seen that the impact on mental health when a small or sick newborn is separated from their mother, kangaroo mother care is prevented, and there's decreases in breastfeeding rates as well. The stigma women encounter as well, returning to their community, also adds to mental health implications for these women. So now let's look at the impact on the newborns. So these are quite significant as well. We looked at the impact of the clinical and developmental outcomes on newborns and children with mothers experiencing CPMDs. So as you can see here, there's several important implications such as low birth weight, less likely to be breastfed, stunting, and poor cognitive development. However, one important note here is that in many of the articles and in our key informant interviews, there was a very clear call to further explore and unpack this causal pathway between CPMDs and newborn health outcomes. So there are many confounders that play a role in this relationship that are not fully investigated or known at this point. There have been several articles that have shown improvement in, say, maternal mental health outcomes with targeted intervention, but not necessarily a resulting improvement in child outcomes and vice versa. So there's more work and research to be done. This graphic here shows the cyclical and intergenerational impact of CPMDs on women and her children. And when looking at mental health as a non-binary, rather as part of a continuum, these impacts can continue over her life course. And if women have more than one child, the impacts can be on the entire family multiple times over. So the COVID-19 pandemic has only added to the challenges, and data continues to come out. But what we have seen is that there's increasing mother and baby separation, limited or no companions allowed with women during delivery. We know the impact of that on both the mother and the child. Reduced care seeking. Women have reported stopping breastfeeding earlier than they had intended. And then some of the most recent data has found that women are reporting more prevalence of sadness, feelings of anger and fear and distress, increased depression and anxiety. And something that has come up a bit in the last 2 days as well is there's been a very significant toll on healthcare workers' mental health as well. So that's starting to be more widely discussed. So given this need and the reality, what is being done? I think it's important to note here that maternal mental health conditions are both diagnosable and treatable. And there is a lot being done given this, and it's important to acknowledge. So this includes global level guidelines, manuals, initiatives. For example, the MHGAP from the WHO, this focuses broadly on mental health, but then there's also the Thinking Healthy program, which focuses on maternal mental health. Some of these interventions or strategies really focus at the community level, others are targeting health facilities. Most approaches involve some sort of task shifting from a specialized mental health professional to more generalized health workers. So this can be primary care physicians at the health center or community health workers at the community level. Most involve some sort of stepped care model in which serious cases with more specialized needs are referred, if there is somewhere to refer them to. And all of them attempt to meet women where they seek care and support. And there's very different implementation strategies for all of them. Some sort of local adaptation of cognitive behavioral therapy is probably the most common approach, but other include family-based programs, parenting skills, mother-baby sessions, play-based support. Providers generally need to be trained in a variety of skills to address women's needs, such as psychosocial and trauma-informed care provision. The most often discussed and heavily evaluated program is Thinking Healthy. This is a locally adapted cognitive behavioral therapy that's most often delivered at the community level through either community health workers or peers. It's been used in over 90 countries and is currently undergoing a major scale up in Pakistan. But when digging deeper to look at how and when these interventions address small and sick newborns and their families, explicitly there is less. That said, one thing that is clear, that was made clear in the literature and our key informant interviews, is that in order to meet the maternal mental health needs of women and their newborns and families during this perinatal period, interventions must be integrated into existing platforms. There cannot be parallel systems or siloed programs that will address the mental health needs of women in the perinatal period. And the current small and sick newborn platforms were mentioned by several key informants as an exceptional place to start. And many also noted that small and sick newborn programs should include maternal mental health as a core component. Here are some specific examples of intervention strategies that have had promising outcomes from women and children. The newborn care intervention programs have seen improvements in depression, anxiety, as well as improved child weight for age. Thinking Healthy, again, improvements in depression and anxiety, as well as improved exclusive breastfeeding rates and reduced rates of child infectious illnesses. Women's support groups, they've improved depression symptoms and improved exclusive breastfeeding rates and reduced rates of infectious illnesses. We've heard quite a bit about kangaroo mother care, which has clear benefits for this small and sick newborn, but has also shown promising results in RCTs to lower the risk of moderate to severe postpartum depression symptoms. Respectful maternity care, or RMC, recent study out of Kenya is showing women's experiences of disrespect and abuse impact a woman's mental health. And many key informants noted that they felt respectful maternity care interventions should be included as a way to improve women's mental health and also those of the newborns. And lastly, as care and outcomes improve through the important work to improve intrapartum quality of care, babies continue to survive and thrive, and thus you're reducing the number of women who have to deal with the mental health burden of experiencing a loss. So where do we begin? There are a few suggestions for where to integrate, and they're not set up as necessarily either or, but rather potential for various places for integration based on the platform. I'll focus on just 3 of these. The first is the community level. There's very good evidence on successful interventions that work at the community level within existing platforms such as community health workers, and that prevent the need for huge numbers of referrals out to the health facility. The second important one for this audience, I think, is this use of newborn as a quote Trojan horse. So in communities where stigma is almost debilitating to talk about mental health, several intervention approaches work through the newborn. Talking to the family about how to help the baby survive and thrive is much easier entry point than addressing mental health conditions head on in some cases. And of note, on the last one, I do want to mention that faith-based organizations and actors are also trusted agents in communities that can have partnerships in this work as well. So where are the gaps? So future research should expand the evidence to include different contexts. This is particularly relevant to women in conflict settings, adolescent girls, and mothers of small and sick newborns. Looking beyond postnatal depression. And the second is better understanding of these causal pathways. So really unpacking what is this relationship and what are the modifiable elements between CPMDs and newborn outcomes. For number 3 here, the identification of integrated approaches, though I did share some examples, one of the very clear calls from our key informant interviews is that we don't have enough understanding and evidence that shows what works for both women and newborn health outcomes. And so there's a need to identify more integrated approaches. So what to consider as we move forward? The first one seems obvious, but this came up over and over in our interviews with people who've been working in this field for many years, is the cure should not be worse than the problem. So acknowledging how stigmatized mental health is in the community, approaches to address the issues, support women, and do so with good quality care are going to be crucial. Very closely aligned is the notion of screening. So there are numerous pushes to institute universal mental health screening for women. However, without access to quality, supervised, and culturally relevant services, there's potential to cause more harm than good. As I've noted, this can't be a siloed approach. The fourth one is human resources at the health center are already stretched, and I think a lot of people have had some important conversations about that. And addressing CPMDs will require additional training. But as I noted earlier, when task shifting to lay health workers at the community level is done well and at scale, this could dramatically reduce the number of referrals and the needs at the health facilities. Respectful bereavement care should be a part of the conversation as well. So we spoke to numerous women from organizations working to support families who've experienced loss. And one of their requests was to continue to include respectful bereavement care into all aspects of the training programs for providers. The way women are spoken to following the loss or not spoken to at all have long-lasting mental health implications for the mother, and in subsequent pregnancies can often trigger even more mental health conditions. Number 6 here is the language used to describe mental ill health, suffering, and depression is deeply contextual. And we must make put in a lot of effort here to understand how women and carers in their own communities and their own words articulate this pain. So doing this takes time. Quick translations of language from tools created in high-income countries into the local language alone simply won't work. And lastly, as I've noted earlier, mental health conditions are they're not a binary. It's not a yes or no. A woman is or is not suffering from this. It really should be treated along a continuum in her life course and needs to be treated as such. So in closing, I'd like to say that addressing maternal mental health is not a luxury. There are life and death consequences for newborns and mothers, but mental health conditions are treatable, and it will take the conviction of people like yourselves to push this agenda forward and include maternal mental health as a core element in the small and sick newborn programs. Thank you very much.
Thank you again, Shannon, for that enlightening presentation, highlighting the magnitude of the problem. Programmatic interventions that could work from the evidence to date, and also the gap and the need for more understanding of effective intervention in addressing this silent burden. Thank you so much. So our last presentation will be by Professor Susan on developmental support care. Susan, for you.
Thank you so much, Tedbab. It's really a privilege to be able to address infant and family-centered developmental care, because really the goal of special newborn care, next slide, is not just survival of small and sick infants, but it's really babies who thrive and reach their full potential. ENAP articulates this vision, and it's more fully explained in the 2020 Survive and Thrive report that you see here. But even more recently, this thematic brief describes how nurturing care can be provided for every newborn, including those who require inpatient hospital care. Next. So in this presentation, I'd like to highlight how nurturing care can be tailored for small and sick newborns through infant and family-centered developmental care. The 5 components of nurturing care take on special meanings when they're applied to inpatient newborns. Good health becomes both preventing and managing illness. Nutrition, as we've just heard, optimizing exclusive breastfeeding or breast milk feeding. Safety and security can translate to zero separation of mother and baby, and respectful care for both in a comfortable environment that minimizes stress. Opportunities for early learning mean stimulating the baby's development through appropriate sensory experiences. And responsive caregiving and awareness of the newborn's signals and reacting to them appropriately. Next. So infant and family-centered developmental care, or IFCDC for short, incorporates all the physical, neurodevelopmental, and behavioral emotional components of nurturing care. At the very center is the baby. surrounded by the sensory environment of touch, smell, taste, sound, sight, and also the sensation that comes with movement. Generally, nurses and healthcare workers are responsible for organizing the baby's environment, optimizing nutrition, positioning and handling carefully, protecting sleep, minimizing stress and pain. But the family and caregivers are essential in this ecological model because their relationship with the baby is one that endures and brings really unique advantages for neurodevelopment. So let's examine each of these components in the petals of the flower that surround the infant. Next. First, optimizing nutrition. And that's by providing human milk, recognizing feeding readiness cues and supporting interaction during feedings, whether at breast, by cup, or by nasogastric tube, is key to successful maturation of feeding behavior. A consistent caregiver, ideally a parent, really does this best. And skin-to-skin contact has been shown to improve breastfeeding initiation and support milk production, as we just heard. And it's also been associated with earlier discharge. Next. Can we go? Very good. Safeguarding sleep involves clustering care. So here, as we see, taking temperature, doing diaper changes, giving medications or other treatments, lab tests, clustering these and synchronizing them with a baby's sleep and wake cycles to preserve periods of undisturbed sleep. Minimizing noise and cycling light become really obvious strategies when mother and baby are together in skin to skin, resting and interacting with one another in synchrony. Next. And minimizing noise and light also reduces stress, which preterm infants express in a variety of ways, not just crying. So the preemie stop sign really means what it says, but also closing eyes, pulling away, going limp can also signal enough for a preterm baby. Creating comfortable nests of bedding that provide boundaries, give babies a sense of containment and help their self-organization. But better yet, the kangaroo position and closeness of skin to skin provide pleasurable touch, familiar heartbeat sounds and smells, and more stable temperature actually, as compared to the conditions inside an incubator or on a warmer. Next. Positioning the infant with limbs and trunk slightly flexed and hands free also helps maintain a baby's organization. Steady touch and gentle movement avoid startle reflexes, and transfers can be especially disturbing and disorienting to these babies. Flying through space really stimulates the vestibular system, which is not stimulated at all for babies who are lying on a cot. And again, skin to skin mimics the fetal experience of containment and gentle motion, but the real advantage comes in the opportunity for reciprocal interaction between baby and caregiver. So talking, responding to even minimal arousals in the baby or changes in facial expression, singing, smiling, holding hands. These are really things that parents do the best. Next. Finally, protecting skin provides a major defense against infection. When mechanical warming devices are used, care has to be taken to maintain humidity, to protect fragile skin, as equipment and tape may cause breakdown. Skin-to-skin care creates a hospitable microenvironment and colonizes the baby with friendly family bacteria. We've heard evidence from the IKMC trial of decreased rates of serious infection in babies who are cared for with immediate kangaroo mother care. So really, for every component that we've gone through, every component of infant and family-centered developmental care, continuous skin-to-skin can provide a superior alternative to what can be provided by nurses with the baby in an incubator or on a warmer. Next. So maybe it's time to stop clinging to an outdated model of care. At one time, as we see here back in the early 1900s, providing warmth mechanically made a life-saving difference. And in the early days of NICU care, medical professionals really needed a lot of access to provide hands-on intensive support, intubation, ventilation, chest tubes, multiple IV starts. But the nature of neonatal care has now really shifted to prevention of respiratory distress with antenatal corticosteroids, to mitigation of respiratory problems with surfactant, to the use of non-invasive CPAP, very early enteral nutrition. And much of a preterm infant's course now is really growth and neurodevelopment. Again, as professionals, we've really tried our best to address these needs as medical treatment using developmentally supportive techniques to provide nursing care and adapt the incubator environment. Next slide. But maybe it's really time to flip our concept to emphasize more continuous provision of developmentally supportive care by parents and family caregivers using skin-to-skin care and kangaroo mother care, and move away from the medical treatment model. This would effectively increase the dose of developmental support, and it would more closely match the sensory environment before birth. It provides physical, developmental, and behavioral emotional advantages, not only to the infant, but also to the family and also to healthcare workers. Next slide. So this is just a summary of what we've considered. In the first column, the components of nurturing developmentally supportive care. In the second, the advantages of continuous skin-to-skin care. And in the third, some of the shortcomings of conventional care. We've heard over and over about the difficulty of procuring and maintaining equipment and the critical shortage of adequately trained nurses for newborns. But one way to extend the reach of our care is really to enlist mothers and families in what they do most sensitively, caring for their own infant. Next. So what evidence is there for the unique advantage of parental involvement? We know that preterm babies exposed to parental talk begin vocalizing earlier and vocalize responsively far more than those who are exposed to nursing staff alone. We also know that sensory profiles of preterm infants are atypical. And these data come from infants who are cared for in incubators, but how would they differ among infants cared for in skin-to-skin? We also know that parental presence and certainly holding skin-to-skin change the quality of movement, arousal, and excitability later on in infancy. And we're just beginning to appreciate that graduates of NICUs, both term and preterm infants who have been exposed to conventional care, have an increased risk of psychiatric disorders in childhood and adolescence. Development in an altered environment changes the way genes are expressed, and those changes may be long-lasting and even passed on to future generations. Next, please. Part of developmentally supportive care is also the forging of a family unit in the face of pretty difficult circumstances. We've just heard in detail from Shannon about how direct involvement of mothers can reduce significant depression and anxiety. We've heard from Kirsten about the benefits to lactation. And certainly we know that it increases self-efficacy and ability to care for the infant after discharge. Next slide. IFCDC has also been shown to be feasible and acceptable not only to families, but to staff. This quote comes from an implementation trial in South Africa, but there have also been large multi-site scale-up studies reported from India and experience with family-led care in Malawi. Improved health worker well-being may be a quite powerful incentive for staff retention and avoiding burnout. Next. So in summary, infant and family-centered developmental care really is a model for high quality care. It puts the baby at the center as a competent communicator and interactor with individualized care for each baby and family that serves to integrate the family into a functional unit. By providing an appropriate sensory environment, it balances protection and stimulation of the baby's brain and recognizes that the consequences are long-lasting. All of this requires health professionals to help direct what is a very complex and adaptive system. In addition to the WHO resources that exist, the scientific evidence-based competencies and best practices can be found at this website for NICU developmental care standards. Next, please. So as we consider the model for small and sick newborn care, it's useful to note how central IFCDC is in the standards for small and sick newborn care. You see here number 6, all small and sick newborns are provided with family-centered developmental supportive care and follow-up. Next slide. And IFCDC also figures strongly in the training of healthcare workers in newborn care. We've heard from Karen about the important initiatives for age-specific competencies in pre-service, in-service, continuing education, and formation of neonatal specialists. Next. So the challenge is to build an enabling environment for infant and family-centered care using each of the health system building blocks to promote zero separation, reconfigure special newborn care units, invest in the workforce and their education, track utilization, follow-up, and link to infant outcomes, design technology for the care of mother and baby together, update basic health coverage to recognize kangaroo mother care, and to demonstrate the cost effectiveness of central family involvement. And of course, revise policies to support zero separation, family engagement, and networks of care. Next. So keeping the baby and family together with infant and family-centered developmental care really has the potential to redefine experience of care for small and sick newborns. Next slide. Thank you so much. And I look forward to questions and discussion.
Thank you so much, Susan, again, for yet another rich presentation. Colleagues, I have been monitoring the chat box for questions, comments, and thank you also presenters. You have responded to many of, almost all of the questions, but there will be just a few. So I will read those and ask, presenters to respond. So for the first, for Adriana, there was just one question. And for Rebecca also just one question. For Adriana, and I think both are for Adriana. So one is, what about temperature watch is one question. maybe the person, the colleague who posed that question can elaborate what he or she means by that. And the other question is, with mushrooming of innovative devices, how does WHO assure the quality of devices, and how do you provide a list of essential devices to Ministry of Health? The other for Rebecca are just comments. There are no specific questions to her. So Adriana, if you could respond to this couple of questions quickly, I will move to the next questions. Adriana, if you are talking, you are on mute. Your mic is on mute, I think. Okay, let's pause that in the interest of time. So for Christian, there are just one question, because the question regarding social norms from Asha, you have responded in the chat box. But one question is, my experience in a US NICU is the availability of donor milk actually increased the mother's awareness of the benefits of human milk and the use of mom. Is there any similar research in low and middle income countries?
Yeah, thank you. And the answer to that is yes. We know that there are examples of that from Brazil. Sushma, I think, has responded. She's documented this and published from her site in India. Yeah, just the short answer to that is yes. We recognize that having a human milk bank and provision of donor human milk can actually increase breastfeeding at discharge. Yes,
yeah, thank you so much. So one question now from Shannon presentation, again, so important to value maternal mental health and integrate this in all we do for small and sick newborn. As you say, there is a strong evidence base for mental health stress for mothers for small and sick newborn, especially if they die or have ongoing disability. Noting also how key it is to link this with bereavement care, also for stillbirths. This is even more hidden. Are you including stillbirths also? And the second question is, thank you for the informative presentation. Perhaps good to have a simple screening tool for early identification of maternal mental health disorder and a strong referral linkage with facilities having a mental health service. Any experience in this regard? So these two questions for you, Shannon.
Great, thank you. So regarding stillbirths, I think this is an area that needs much more work in. We were able to interview several representatives from NGOs that are working with hospitals and communities on how to train providers to have more empathy and sort of the implications of how women are treated. But I do think this is a big area for more research and understanding. We have a massive landscape analysis that should be out. It's about 100 pages that does include a section on stillbirth. So I'm happy to send that link once it's ready. And the second question was on, I think, a simple measurement tool. So I'm happy, there are several very spectacular humans that I have come into contact with through the last year that are working on these issues. I think nothing's simple in measurement, they'll say, but I'm happy to provide some linkages. And I know that we're in conversations with various global and national level organizations, representatives, about how do we think about measurement in a way that matters. And any of you have sort of looked at this literature, it's fascinating. You know, every study, every article has a different cutoff for whether or not a woman is considered to be suffering from some kind of CPMD. So oftentimes it's really difficult to have any kind of overarching prevalence. I think the Respectful Maternity Care world experienced this as well. So I'm happy to share some links with some colleagues, but this is going to be an issue that I know we at Momentum are trying to be a part of the conversation as we move forward of how to keep it simple, but also make it meaningful and relevant to the women.
Thank you, Shannon.
147.
So we have a couple of questions for Susan. So one is, can you please expand what you mean by reconfiguration of neonatal care units in the context of developmentally supporting care? The second is, we would like to hear your thoughts in implementing the zero separation during current pandemic, where both health workers and caregivers have some fear of getting the baby contracting with COVID. Susan.
Thanks, Tedpa. With respect to the reconfiguration, I think we saw a really new model yesterday with the maternal newborn ICU, caring for mother and baby together from immediately postpartum. But maybe as an interim move to that, just facilitating parental presence 24/7 beside the baby and involving the family very directly in care. So it really does mean thinking about space differently and making space for parents and including them. With respect to the COVID-19, you know, I've been in the middle of that, and I think we've learned a lot over the past couple of years. We know now that most transmission is just by conventional respiratory transmission. And now that we have more adequate PPE in most places, if mothers can adhere to using PPE and have adequate hand washing, it really is possible to prevent transmission. Also involving fathers and extended family as care providers. If mothers are very sick, obviously they have to be separated, and they aren't able to directly care for their newborns, but still can provide expressed milk that can be fed by other family members.
Thank you. Thank you so much. So I think we have to wrap up. We are a little bit over time. I would really appreciate and thank all the presenters for the rich, lively presentation, and also participants for active engagement. The chat box is really busy and full of, you know, a very important conversation in this topic. So thank you again. This conversation, and most importantly, the action continues until, you know, we make sure that every newborn survives and thrives. So I conclude this session, and over to Rajiv.
Thank you. I think we are in the break time now. But before we go on to break, I think I'm right, right? We finished. Yes. So before we go on a 10 minutes break, I'd like to make a request to the participating country teams. We asked you on the first day about what lessons you had learned about, you know, from what you heard other countries do, but we haven't really asked you about where you are in your journey towards having sick and small newborn care in each hospital, in each district, etc. So it would be really nice if you could type in brief messages in the chat box over the next 15 minutes or so to say what you want to share with others, particularly the countries that did not share their experiences. So we are not asking India and Brazil and Argentina and Uganda, etc., Sierra Leone, Bangladesh to share their thoughts. We've already done so. But the other countries which haven't done that, if you would like to share something in the chat box, make a nice short message, that would be really helpful. And if you want to speak about those, we will give you a minute each to do that after the break, before we start the open house session on the generic model, which my colleague and friend Louis Pearson from UNICEF and I will moderate. So please do write in the chat box. It would be really nice to see we are at the sharp end of this very nice meeting, but I think this is the time to now pull everything together and go ahead. I would ask us to do that if possible, take a 10-minute break, come back 5 minutes past the hour, about 12-minute break, let's say, and Louis and I will moderate this last session together. So let's go on the break with small piece of work for the country teams during the break to type in a message about where you are, what have you been doing, what are your plans for the future, not in detail, but in summary. Thank you so much, and see you in 11 minutes from now, 5 minutes past the hour. Thank you. I think we are almost there at time. It's a minute to go. Yeah, it's about 3:05. Maybe we should just start. Louis, would you like to make some brief comments before we start the final session and ask a few countries also first to share what they have to say? I'm sure, at least I know that Mozambique wants to say something, but if any other country wants to also make a few comments in addition to what people are writing in the chat box, that would be great. But Louis, to begin with, any comments from you on behalf of yourself, UNICEF, please go ahead.
Sure, Rajiv. It has been a great 3 days, and I listened to many important lessons, experience, and stories from countries. And how much I wish this could have happened in person through joint field visit. But here we go, learning how to connect through Zoom calls. On the first day, Rajiv, you mentioned a very important figure, that is, in the world, we have a clear dream in mind. That is to bring the neonatal mortality rate from 18 to 12 before 2030. That is a number that we have all in mind, how we can make sure that every country, every district, and every community could reach this target in an equitable manner. It requires effort from leadership from the government. It needs more investment. Often visiting the newborn care unit, I realize how much it costs the health system and the cost of families. So how we can work together to make sure that this available care, whatever a country can afford with their current domestic investment and some ODA support, can be scaled up and can be covered by health insurance, as WHO's ambitious target of universal health coverage. It's critical. Many of those services will not be available unless we can bring down the price, make it more affordable. I also learned throughout the 3 days on the importance of longitudinal tracking. It's not just about having a sick child admitted and treated, but starting from pregnancy and the concept, the first 1,000 days, the time of delivery, improve of quality of care, and reduce stillbirth, then birth registration, breastfeeding, immunization, development milestones, then nutrition, and the prevention of and treatment of common diseases. I feel we need to look at how we can benefit the concept of 1,000 days to make our effort more integrated from communities and households to referral health facilities. UNICEF works in more than 100 countries. We are ready to commit ourselves to support the sick and small, but also maternal newborn care and the multi-sectoral programs, nutrition, education, and adolescent health, and prevention of early marriage, and mental health, social protection, and many other things. I also really appreciate the learning and the collaboration from partners. When Hema yesterday shared her session, I realized it was 3 a.m. in Seattle, and that kind of commitment from colleagues and many colleagues stay till late into the evenings in Asia. So just from UNICEF, I want to commit on behalf of our leadership and our program, and as our country offices, to the effort of maternal newborn care, and be a good partner, be a good learner from countries and the partners to give our best to the world. Thank you, Rajiv.
Thank you very much, Louis, for those nice words and summarizing some of the things that we have been listening to. I'd like to ask the Mozambique team if I know you have said that you will send a presentation, but if you want to summarize what you wanted to make some comments, please go ahead, Mozambique team. Would you like to make...
Boa tarde a todos. Vou falar em português. Posso continuar?
Yeah, we can hear you. Go ahead. Yes.
Não sei se me ouvem.
Yes. Yes, we can, and the translation's working well. Thank you.
Bem, eu não ouço o retorno.
Podes falar, Ivana.
Tá bem. Ok.
We can hear you well.
Boa tarde, eu sou Ivana Dias, sou neonatologista do Hospital Central de Maputo e estamos com um projeto já desde 2018 com apoio do nosso governo, apoio da UNICEF e apoio da Associação Moçambicana de Pediatria. Então, Moçambique tem uma taxa de mortalidade extremamente elevada ainda, neonatal, cerca de 30%, e devido a isso nós temos vários níveis de atenção, nível comunitário, temos nível 1, que é para os centros de saúde, que é nível primário, e alguns centros de saúde têm maternidade, onde em quase todas as maternidades temos um canto de reanimação do recém-nascido apenas. Aquele que nasce mal é transferido para o nível 2, que é o distrital. Esse nível distrital, temos um pequeno, podemos chamar uma pequena unidade neonatal de internamento. Nessa unidade neonatal temos apenas suporte respiratório com oxigênio-terapia, e tem clínicos gerais, não tem pediatra, e tem enfermeiras de saúde materno-infantil. No nível provincial, temos um hospital que tem uma unidade neonatal um bocadinho maior, e que algumas unidades têm capacidade cirúrgica, não todas ainda. E a maioria delas não tem outro suporte respiratório que não seja oxigênio. E o nível terciário, que é depois tem um nível terciário, que é o hospital provincial, que já falei, e o nível quaternário, que são os hospitais centrais, onde tem especialistas, enfermeiras com pouco treinamento neonatal. Então, devido a esta alta taxa de mortalidade, devido a esta falta de treinamento neonatal, então propuseram à Associação Moçambicana de Pediatras para fazer um pacote de formação. Isso em 2018. Nesse momento, pegamos as províncias com maior taxa de mortalidade neonatal e começamos a treinar mentores provinciais. Nesse pacote de formação, para além de darmos aulas teóricas sobre as principais patologias neonatais, também dávamos aulas práticas sobre o manejo dos equipamentos, porque a maioria das enfermeiras, na sua formação inicial, pré-service, não tinham esta componente neonatal. Então, o que nós fizemos foi adequar um pacote de formação para que elas pudessem trabalhar e manejar os equipamentos, porque os equipamentos neonatais estavam todos guardados no armazém. Então, a partir desta formação, começamos a formar primeiro os hospitais centrais, a seguir os hospitais provinciais, e tinham a missão, estes formadores provinciais, de chegar até aos distritais. Nós, os pediatras, os neonatologistas, fomos até as províncias, formamos os distritais também, e por sua vez estes distritais foram formar os colegas. Então, neste momento, nós estamos numa fase de fazer mentorias, vamos até os distritos, vamos ver como estão em termos de conduta clínica, como estão a usar os equipamentos que a UNICEF está a doar a estes hospitais distritais, e começamos também a fazer monitoria das mortes neonatais, que também faz parte do nosso plano do governo, que é controlar as mortes neonatais, notificá-las, discutir, para ver se melhoramos um pouco a nossa mortalidade. Em relação ao canguru, dizer que o canguru é feito já há alguns anos em Moçambique. Acho que aqui, acho que no distrito, a separação zero acontece mais do que nas cidades. Nas cidades nós temos incubadoras, temos outro tipo de mães com um pouco de um nível social mais elevados, e no distrito é mesmo a família, é a comunidade que está presente nos hospitais. E elas praticamente exigem o canguru, porque elas não saem da unidade até que o bebê tenha alta. Então, quer queira, quer não, nós estamos a fazer a separação zero. Não sei se tem alguma outra questão que eu possa falar. E também enviamos uma apresentação para elucidar melhor o nosso trabalho. Obrigada.
And from Zimbabwe, Rajiv, there is an interesting message that they use the word of jealous to express their feelings. I feel in Zimbabwe in the last decade, you've been doing a lot with support from donors to uphold the essential services. I'm aware through the health development funding, and the partners are topping up the frontline healthcare to continue basic maternal newborn services. And I think you have a lot of support from partners to do more. But I welcome you, Zimbabwe, if you like to come in to tell us exactly where you think the government and partners can support you more in maternal newborn care, please.
Thank you very much. And Zimbabwe would like to make a very brief comment. Please go ahead. I'm also going to request the Pakistan, either someone from the ministry or from the WHO country office. I think I saw a comment to make a 1-minute intervention as well, so that we can then go on to the summarization of this workshop and where we are going forward with it. So 1 minute each for Zimbabwe and Pakistan, please. Anyone from Zimbabwe? Perhaps you summarized your thoughts in your comment of excited, committed, but jealous of some of the other countries that have made progress. And I'm sure, as Louis said, we can.
Competition is good, right? Healthy competition. Yeah.
Thank you. Pakistan?
Thank you, Dr. Rajiv. I was hoping that our colleague from one of our district hospital, Dr. Jawad, could join. He was facing some issues in connecting. So he would have probably better provided the insights from the district level. But as far as we understand, there has been a dearth of specialized newborn care facilities at district level in the country. However, with the current focus on UHC benefit package and its implementation, and also because of the fact that Pakistan remained too slow on improving newborn health outcomes in the country for more than decades. So there has been an enhanced interest and focus and attention towards improving newborn care services at all levels. And if I speak from the WHO's perspective, like just over last couple of years, we have supported number of newborn ICUs and even KMC centers. And likewise, UNICEF Pakistan is also investing a lot in Nicus and also establishing KMC centers across the country. So that sort of course, remains too little, and unless there is a commitment and an ownership by the government itself to scale up such interventions, which we are hoping to see with this current drive towards implementation of the UHC benefit package. Luckily, the UHC benefit package does include care for the sick, small and sick newborns at the hospital levels. And we are very, very hopeful and very enthusiastic towards towards witnessing it, its implementation and seeing it happening in the country.
Thank you very much, Uzma. Kutsia, that was great. Thank you. I would like to now request Zambia to make a 1-minute submission as well. If you want to make, please go ahead, Zambia. You've just
Thank
asked.
you very much. Yes, thank you very much for this opportunity to speak. So in Zambia, it seems we have the same problems as everybody. WHO interventions like IMCI have actually taught people how to refer patients to the hospital. So most of the mortality is actually seen at hospital level. And like everyone else, we have a shortage of specialized nurses and neonatologists. I know that's not really the way to go, like somebody had said, but we have started 2 nursing programs. One is a 1-year advanced diploma, and the other one is a master in neonatal nursing. So the idea is that when the master's students actually complete their program, they'll be the lecturers for the advanced diploma nurses. So currently, these programs we've started are being carried mostly by pediatricians, and we only have 1 neonatologist. And we admit the fact that a neonatologist may not teach what a neonatal nurse can actually teach. So we're actually making a request to have a trained neonatal nurse practitioner from outside Zambia who can come and spend maybe 3 months or 6 months to actually be a preceptor to these training programs, especially for the master's program, so that they will have that hands-on experience and they'll have the exposure that they can use to teach the other nurses once we continue training. Thank you.
Thank you very much for that intervention. Any other country team that may want to share their thoughts at this moment? Please go ahead before I ask some of our partners also to share their 1-minute thoughts on how they think we can move forward. And then we will go into the summary of the Philippines. I see you have made somebody from Philippines is making a comment. If you want to speak, please go ahead.
Hello again. Good evening. This is Tita Oy from the Philippines. And what we did, because our training courses for the care for the small baby has stopped because of the pandemic, we were asked by I think WHO to make an online course, and we already conducted once for 6 hospitals, and we're supposed to roll this out to the other hospitals in the other regions. But right now we're doing it for the regional hospitals, and we're hoping that this will trickle down to the district hospitals. But that's what we're doing right now. But with regards the equipment, I learned a lot that there's some, especially for the CPAP, that we really need to discuss this with our Department of Health with regards budgeting as well as training and maintenance of this equipment.
Thank you very much. Anyone else? Burundi, I see you have made somebody from Burundi is writing in the chat box. Would you like also a minute to speak about your comment? Anyone else? Burundi or anyone else from any country? The Burundi team?
Oui, bonjour. Bonjour.
Oh, maybe the internet connection is not good.
Bonjour.
Dr. Bridget, we are unable to hear you. We are very sorry, but your internet connection doesn't seem to be working. Okay, anyone else from Ted Barb is asking from Niger, Burkina, any other country team? Please unmute yourself before you speak.
Oui, bonjour.
Oui, s'il vous plaît, Bridget, continuez.
Yes. Oui, merci. Au fait, au Burundi, on a commencé un programme de mentorat avec les sociétés savantes. Donc, l'OMS a appuyé, en tout cas, l'élaboration du document national des formations. Et l'objectif vraiment, c'est de former les médecins, les infirmiers du bloc opératoire, les infirmiers de la maternité et les sages-femmes. Et donc, pour chaque pool de formation, nous avons 15 participants constitués par des médecins, des sages-femmes, des infirmiers qui travaillent dans la maternité. Et donc, l'objectif vraiment, c'est de renforcer leurs capacités théoriques sur les soins néonatal et obstétriques de base essentiels et aussi sur le soin obstétricaux et néonataux d'urgence complet. On fait des formations théoriques et après, on fait vraiment des stages pratiques dans les hôpitaux des districts. Et cela, on travaille vraiment avec la JICA, l'UNICEF et on appuie aussi dans les équipements pour pouvoir accompagner ces hôpitaux des districts. Voilà, ça c'est la stratégie pour le moment qui est en cours au Burundi. Voilà, on estime que d'ici 2 ans, on pourra vraiment former chaque année au moins 3 sessions de 3 sessions de 45 médecins, ce qui fait que d'ici 2 ans, on pourra former autour de 180 prestataires de soins, dont les médecins, les sages-femmes et les infirmiers. Voilà.
Thank you very much. From the countries which actually made presentations, I see that some people would like to add. I don't know if Jessica, if you would like to add, and then have seen Sushma has asked that if she could add something quickly before we go to other partners. So Jessica and Sushma, if you want to add anything. Sushma, if Jessica is waiting.
Okay. So
Rwanda.
Sorry, please go ahead from Uganda first, then if you can, if you want to add anything before Dr. Sushma from India.
C'était le Rwanda.
Rwanda as well. Okay, we will come to you in a moment.
C'était le Rwanda. Okay, okay.
So if not from Uganda first, then India and then Rwanda. So India, Sushma, please go ahead.
all right. Thank you, Rajiv, for this opportunity. Our country has made the presentation on day 1. So in addition, I just wanted to add on for those countries which are now beginning to start these SNCUs or the level 2 units. The 2 things that we found from our experience to be important were that we had trained the doctors and nurses together in one go in the same sitting. That is one. And second thing, after the workshop or the training, it was very important that they are at a center which is practicing all the good clinical practices. They are there as observers, and they are there for a period of 2 weeks. Since it's a large country, we couldn't afford very long period, but if people are planning, it could be 4 weeks, which will be really useful for them to be a part of the system, learn from there and carry back some learnings when they start their setup at the province level or district level. Thank you so much.
Thank you, Dr. Sushma Nangia. Yes, Rwanda, you had unmuted yourself to speak. Please go ahead.
Thank you. It's Assumpta. I work with USAID Ingobi activity, intra-health. So I want to add in what was presented in the Neolance presentation. So now currently, I can say the coverage for inpatient care for small and sick newborn is good in Rwanda. Now we are more focusing on quality. So one of the program we had for improving quality of care for newborn was the mentorship program that is done from mentors from teaching hospital who are mentoring the district hospital. So since like 4 or 5 years, we were working with pediatrician, but for this year, we add neonatal nurse specialists. Now they are part of the integrated mentorship, and we are seeing very promising result where in some districts we have already decrease of mortality due to the focus they have on infection prevention and control. They are focusing also on well use of equipment and also implementing family-centered care. So this really is giving good result, and we hope in the next meeting we can present the findings. Another intervention is the Pediatric Development Clinic that is about the follow-up of newborn at high risk. who are discharged from the neonatology unit and follow up in health center. So this program was started in a few PIH supported districts. Now with this good collaboration we have with PIH, we are scaling up in 2 new districts, and also this also is giving good result. We hope to scale up in other districts for the next year. So, for example, for babies who have problem of growth, we can identify those problem on time, and those baby are linked to the nutrition program, and those who have a problem of delay of development are linked to the ECD program. So we hope really that it will give a good result. Thank you. Thank you.
Thank you very much. I would like to also, in the next couple of minutes, maybe we have a few more minutes to spend on this, but it would be good to hear in this open house. If anyone, I see one hand, I'm going to come back, but if any of the partners, particularly the ones that didn't have the floor yet, if you already have made a presentation, etc., we can wait for, if we have time at the end, we will come back. But if you haven't had the time or made a presentation so far and would like to make a brief statement or any comment, could you please raise your hands? I see, for example, AAP, Jana is here. Some of the other people who haven't had the chance to speak but would like to, please do raise your hands. I have one hand raised, Yaye, Dr. Yaye, get to.
Yes, this is actually from Ethiopia. So after the invitees have spoken, I guess I can do mine, because we have presented Ethiopia. Okay, thank you. Okay, thank you. Good afternoon, good morning, everyone. As I said, this is Yaya from Ethiopia. I'm working for UNICEF. I know Ethiopia has presented on the first day. Because of some technical issues, I was not able to attend the whole presentation, including ourselves. Our presentation, we have contributed in the PowerPoint presentation. One thing probably which we might have missed in our reflection is, Ethiopia has made, as you know, good progress in terms of child health, including newborn health. Also, there are still some challenges in maternal health, but we, could have, in terms of our challenge, you could have mentioned, the current conflict which is going on in the northern part of this country. The conflict has actually covered a large part of the country, and it's a really very saddening situation that I can say we have self-destroyed, self-mutilated ourselves. In all the conflict areas, all the health facilities, I can say, are either destroyed, equipments are looted, equipment are damaged. So we are, as Louis, who has visited one of the facilities, thank you for that, Louis, in one of the regions, said it is almost taking all facilities to ground zero. So all the gains in those areas in 3 regions have gone back to zero. I think all the infrastructures are destroyed, equipments are stolen or destroyed, either deliberately or or inadvertently. So I think the country is in a serious challenge in terms of all areas or areas of services, including health, education, and other areas. So in terms of health, although I know in this forum there are no big donors, but you can be our advocates to rebuild the country. So I think it's just a kind of an appeal, a short appeal to all of you. Thank you so much.
Thank you very much for that sobering comment from you, how all those advantages can be lost very quickly. I have 4 hands at the moment, and I would like to limit to those 4 hands. And again, I really request you to be brief, because we do need about 20 minutes for the last session of kind of summarizing this and getting your thoughts on other issues. So very quickly, Steve, Jana, Jover, and Mariam. Steve, you are first. Please go ahead.
Thank you, Rajiv. And I'd like to just say that we're very happy and pleased that Save the Children could participate in this. And it's been a wonderful learning experience to see what's going on in countries and to really learn what are some of the challenges that we have to face and we have to work in support as a partner for countries. Just want to say, I think one of the major take-home messages is really reinforcing what we're doing at SAVE and what we're focusing on, and that is particularly the zero separation and all of that entails with KMC, developmental care, family-centered care, breastfeeding. I also want to mention innovation, that we're looking at some program innovations that we can try out. And so this is one of the areas that we're going to be focusing on in the future. Lastly, I would say that we want to use our platform, Healthy Newborn Network, to help promote any of the learnings that can be disseminated and shared broadly with the newborn health community. So we're really committed as a partner, both to programming, but also to information sharing. Thanks.
Thank you very much, Steve. And your contributions from Save the Children. Jana, please go ahead.
Thank you, Rajiv. It's really been such a pleasure to hear from so many countries. And I think one of the key messages in thinking about how we move forward with small, sick newborn care, and especially this very important new concept of zero separation, is making sure that we're making all of these linkages and that we're bringing together the great work that so many people are doing. And we have been lucky with the support of CIF in partnership with Cadre and in linkage with MCGL and NEST 360 to work in Ghana on this very topic of small, sick newborn care, and really approaching it with that health system strengthening and using quality improvement and direct observation as the primary mechanisms to customize curriculum. Of course, working with the Ghana Health Service as well. So I think that's an example of a microcosm of how we can approach this work to make sure that we're including many partners and making the zero separation concept at the core of a small, sick newborn care. And just one other comment I will say, I think this last 2 years has really pointed out the critical importance of digital tools and availability of digital tools. And I know many have tried to do this, and I'm going to put a link in the chat to some that are currently available online to support maternal and newborn care. So I hope that we can continue to use these tools. I think one of the joys of this meeting being virtual is that so many people are able to participate from so many places. And I hope that innovation we don't lose going forward, because we love to meet in person, but I think it's also so important to be able to be inclusive of as many sites as possible. So that's been a really wonderful innovation here. Thank you.
Thank you very much. Jover?
Thank you so much. It was very wonderful to follow this conference. I'm a pediatrician working in the Republic of Central Africa with Doctors with Africa, COA, at the complex pediatric hospital. It was really amazing to see what is happening everywhere. What I can say, here in the Republic of Central Africa, the pediatricians who are there are working hard as well, specifically Professor Godi, who has initiated the program of postgraduate of pediatrics. They are having now 22 residents soon in 2 weeks. The second batch of pediatrician of 6 residency, I think, will be graduated. They have initiated the good partnership of Pediatric Association and the Association of Gynecologists, where they are doing some meetings to see what can be done in terms of improving maternal and newborn child health. And this conference, when I was following it, I have seen that there was a lot of to learn from different corners. And I'm sure that here as well, there was different initiative which is going on. And we hope that with the support of UNICEF, and we have discussed with WHO, the things can be moved ahead and no one will stay behind. Thank you so much.
Thank you. The last comment from Mariam before we go to the summary. Please go ahead, Mariam Sissoko. Sure, I don't think I can hear anything. I'm sorry, but seems there is some problem. So I think we should just move ahead and see if we can have time. We will come back to more comments.
Hello.
She's there now.
Hello.
Go ahead.
Oui, vous m'entendez maintenant?
Oui.
Ok, je m'excuse, je n'avais pas porté le casque. Je disais que moi, je suis dans un bureau de zone UNICEF dans la 3e région du Mali, à Sikasso. Et j'ai été très contente de participer à cette session de 3 jours. Ça m'a permis de passer en revue tout ce qui s'est fait déjà dans le pays. Vous connaissez le contexte du Mali aujourd'hui, qui est un pays confronté à beaucoup de défis sécuritaires et tout le reste. Mais j'ai vu que quand même au niveau national, on a pratiquement les structures de niveau 1 à échelle nationale. Et avec l'appui de l'UNICEF, nous essayons de renforcer certains districts sanitaires. Nous avons noué des partenariats avec 2 sociétés savantes, à savoir l'Ordre des sages-femmes et l'Association des sages-femmes, et ensuite l'Association des pédiatres pour réduire la mortalité maternelle et néonatale dans la région de Sigasso et de Ségou. Et au niveau communautaire, nous avons beaucoup d'outils. Et nous travaillons beaucoup dans l'implication des communautés à Sigasso. On est en train d'expérimenter une approche de mise en place de plateformes communautaires intégrées où la communauté est au cœur de son développement et ça parle de tous les aspects. Nous sommes en train de faire une collecte de données et bientôt nous allons analyser pour partager au niveau de l'UNICEF Mali. Comme les insuffisances qui ont été signalées, vraiment, c'est le leadership de l'État qui fait que autant de données produites ne sont pas analysées pour prendre les bonnes décisions. J'en veux pour preuve seulement les soins SMK qui sont là depuis des années. Les gens mettent en œuvre, on organise des revues pour les SONU et intégrés à la PTM, mais au vu des résultats, on sent qu'il n'y a aucune analyse pour que les gens prennent des décisions au moment où il faut. Le problème des ressources humaines vraiment est crucial au Mali, mais il y a des projets qui sont en train de renforcer maintenant les aires de santé au niveau CESCOM pour mettre des sages-femmes. On espère que tout cela va amener un changement qualitatif. Merci de nous avoir associés à cette expérience. Je pense que l'équipe santé du Mali prendra soin d'exploiter au maximum tout ce qui a été partagé. Et je voudrais terminer à dire à lui et personne que le petit Daouda qu'elle a vu en passant à Bouni est encore en vue. Le grand malnutri que vous avez vu, il est encore en vie et il se porte bien. Malheureusement, il a des séquelles neurologiques. Merci à tous. Merci beaucoup.
Thank you. So I would suggest, Lue, if you want to make a few comments while the slides come up for the components of the model. Lue, over to you. And if Olive or her, could you bring in the slides? Lue? Okay. Then I can show this in a moment, Lue, if you permit.
Please go ahead, Rajiv. I've been reflecting on how important it is just to remember the basics of such as having wash and sanitation, the basics of having the essentials such as oxygen and oxygen blenders that just came in. In many parts of the world, we're moving far ahead, but in many other parts, we really need to invest more in the fundamentals, the foundations of the system and the basics elements to get the maternal newborn care right. Just a reflection. Over to you.
Thank you. Thank you very much, Louis. So I'm going to try and kind of talk through some of the lessons that the core team, the WHO, UNICEF, USAID, BMGF, other core members, we have been trying to pull together from this great 3-day meeting. I think we heard some wonderful presentations from countries, and so many of them from 3 different continents that gave us an idea of how they were able to achieve what they achieved. In addition, we had some very, very important and interesting presentations on newer ideas or specific things within newborn care that were critically important, like the concept of zero separation, immediate KMC, the human resource, how important it is, the equipment and why the correct equipment, sustainable equipment is so useful, so important, and then the developmental care, maternal health. And we thought that we should bring together some of these core components together as a generic model, which can be then adapted at the country level. We have these 10 components that we have pulled together, but of course it is open to, this is draft, and we would like some feedback from the group now and as we go along. So the 10 components that we have pulled out is having a vision and political commitment for us to be able to move forward in a country, without which it is almost impossible to make progress. Any country without the national commitment of the political highest level commitment has been not able to move forward very much. And then the key question is, from the very beginning, planning at the national level, not in piecemeal, not in just trying one pilot project or one pilot area in one district or 2 districts. And it is the core fundamental of this planning is based on the sick and small newborn care standards, which define what is it that we are trying to deliver. But then the issue of adequate and sustainable financing, the availability and capacity of human resource, the appropriate infrastructure that may be needed, and as we saw, not only of the past, but how we want to do the infrastructure of the future, which brings in zero separation into play. Equipment, we heard so nicely today from Rebecca, Adriana, and others, the issues of having the appropriate, robust equipment, but also to maintain the equipment and move forward. Then we talked about the linkage with maternal health, which to us is, before that, I forgot about number 6, which is the robust data system and use of data, which was illustrated from so many countries as being a critical component of this scale-up model. The maternal care, whether it is pre-labor or labor care, whether it is childbirth care, or the care in the postnatal period, which takes into account not only maternal health, but also, and which is physical and mental health, but also maternal well-being, is central to any effort that we can to make it successful. Family involvement in care of the sick and small newborns came out as a very strong component, very strong message, as to the focus being not just the provision of care, but also the involvement of families and support to families. As a overarching concept, although it is part of the sick and small newborn care standards, we took out two things out of this, which is not only to think about that immediate survival, but also provide developmentally supportive care to the babies, and to make sure that there is post-discharge follow-up, including early intervention for those who need it. We have spoken so much about retinopathy of prematurity, about developmental delays, etc. Of course, quality of care and the coverage is cross-cutting. We have not elucidated each and everything under the sick and small newborn standards, the core care, the principle being we want the babies to survive, but we also want the babies to thrive. So the core things which interventions which are delivered, this system is not just the infrastructure, not just the equipment, not just the human resources, but a commitment that every baby gets the care, that gets those interventions which are highly effective in improving survival, but also effective in making sure that those babies survive in a way that they can thrive in the future. So that is one thing which we wanted to put to you and get your thoughts and comments. I'm already seeing some which are coming in the chat box. So please continue to write in the chat box all your comments until we finish. And we'll keep this for a while for you to see that we want to build this generic model in consultation with all the countries that are participating in this workshop and beyond. And what we do, we can tweak on some of the words, we can change some of the titles to be more inclusive. That is all good. But if you want to, if you think we are missing on a big piece, please do write in the chat box so that we can include that as we move along. So I'm going to leave it on for a couple of minutes without, don't change the slide. But if anyone wants to, Louis, if you want to add to that from your side, anything, or Gagan or Tedbab or Tashoma or Karen, why don't we do that while people look at it and think as to what are the core issues. Lily, Hema, please feel free to also contribute at this stage while people are writing their comments. So this is for the WHO, UNICEF, USAID, BMGF team, etc., to make some additions or comments at this stage before we get to the feedback from the participants, which is, I think, coming thick and fast in the chat box. Louis, starting with you.
I think the 10 are very comprehensive. It just shows how the organizers of this meeting, WHO, UNICEF, USAID, BMGF, and many others, have been thinking this through. We can tweak different elements, but I think we are in the right direction to frame the most important component under a comprehensive and the primary health care or UHC kind of approach, emphasize the importance of government leadership, domestic financing, and the national and sub-national level planning and data. And if there is one thing I want to see more is perhaps it's implicit under number 6, the robust data system, and let us look at whether we can articulate results a little bit more, how this 10 component will be linked to more concrete results and how we measure our success. Thank you, in the near term and long term.
Lily, thank you very much, Lue. Lily, you also have your hand up. Please continue.
Yeah, I'm really very excited about all what we have learned in the past 3 days. So what I want to say about this particular slide that you have shown here is that, why are we calling it generic? Because we think that these elements are all systems-based. Some of them are new, some of them have been, around forever. They just need to be strengthened, continue to be strengthened. But this is generic because it can be adapted in any setting. I saw in the chat box, can this be used in fragile settings? Yes, it should be. We should be able to use this generic model in a fragile setting, in a very mature, strong health system setting, wherever. It just needs to be adapted, which is why we're calling it generic. And also, we need to think of this as a roadmap or a journey that every country will take. So because it's a journey, some countries are beginning the journey. Other countries like India, for example, is probably at the sort of much later part of this journey. Of course, there is a lot to be done even there in terms of increasing coverage of SNCUs in India, but they are really very mature right now in this journey. So this is why I just want to sort of clarify why we're calling it generic, because it should be adaptable for any setting by any country. And I'm really excited about the 10 components. I feel like they are very comprehensive, and you could actually include some things that are not specifically mentioned here, such as nutrition, feeding, and all that. You should be able to find some place for it, for nutrition, in some of these components. So I feel like it's comprehensive enough to be able to include things that may not like jump out. Respectful maternity care is another word that we should have seen here as cross-cutting. But I believe respectful maternity care could be part of number 9, where it is part of nurturing care, respectful care, nurturing care. To me, those are kind of in the same realm. So those are my comments. I'm just trying to read the chat box and see what others have to say. Thank you.
Thank you very much, Lily. And Gagan, would you like to come in for a minute? Or then after you, maybe Teshoma, and then I have Rajesh. And then we will get back to the participants again and the chat box questions. Gagan?
Thanks, Rajiv, and thanks everyone for the inputs in the chat box. And just to be clear, this is more like an umbrella. Each of the component is a broader umbrella under which many pieces will fit in. Like when we talk about the post-discharge care, that will also include screening on discharge, including the ROP and all those things. So it might not be explicitly visible right now at this stage, but when we go to the deep down in each of these heads, there will be subheads including those kind of things. Similarly, breastfeeding will be an important part of the maternal well-being and the lactation support. So some of these things, based on your inputs, can be further revised, but it's more of a broader thing. And under this, a lot of the other things will fit in. Over.
Thank you. Teshome, would you like to quickly add something before we go to Rajesh and Hema?
Yeah, thank you very much. Thank you, Rajiv. Thank you, presenters, participants. This has been a wonderful session. We have learned really a lot from countries. The contribution was amazing. This is really a brief outline of the minimum components that we need to consider. But the basis for this is really the WHO standard for improving care for a small and sick newborn. So that if you unpack that, then you will see everything within these 10 components: the respectful care, the nutrition, communication, referral, all these would be there. So it is a matter of just unpacking but this is a good start, and thank you for all your contributions. Thank you so much. Over, back to you.
Thank you, Teshome. Rajesh, and then Hema, and then we'll move forward.
Yeah, thank you so much for all this contributions and then bringing this together. My sense is that we still need to evolve this little bit further. This is more structure, some processes, but process of care itself, manifesting as continuous quality improvement, is a background music which cannot be, left out. So this is more structure of the unit. But when we do this data and data using for continuous quality improvement, so we explicitly some additional thoughts on that, and then outcomes in terms of case fatality rate. Although data is mentioned there, but if death review systems can be strengthened as also appeared in chat. So while we lay this out in a framework, I think we will have to do universal health coverage in terms of coverage, quality, and financial support. So whether that fits in policy is one entry point there, but to be able to demonstrate that this is more than the structure of the unit, it is the teamwork and the quality improvement process going on, and all of that stuff to monitor the progress. Over.
Thank you, Rajesh, for those very nice thoughts. Hema, over to you.
Thank you, Rajiv, and thank you to all. This has really just been such a wonderful learning experience, and to hear from so many how much give space for the surfacing of so much important and rich experience and expertise, true expertise from so many countries. So I'm really grateful to the organizers for doing this. I think, I think so many people are adding in many, many points, and I think it will be an important task for the organizers to try to take, to honor that and take that into this. I think, as you said, as Gagan and many have noted, these are kind of big buckets, and I think a lot of the nuance of what goes into them is included, it needs to be fleshed out, and grateful to all of the contributions coming into the chat for that. I do see maybe a couple areas when you asked about big buckets that could be missing maybe, or need to be called out. And I think one I'm seeing in the chat that I think is really important is this referral system. So that all of this is only as good as there are patients who are identified and brought into these facilities. Otherwise, they are empty, beautiful homes, and we don't want that. So to some, I think that maybe is implicit in infrastructure, but I think we'll have to look, because some of these areas are a bit more fleshed out, whereas others are totally implicit. So I think we'll have to kind of look at it through many lenses to ensure the equal kind of the appropriate sort of weighting there. And in that, I think another area that has been called out in the chat and was in my mind too was just the core clinical content. Where is that exactly? It's part of a lot of these pieces, but I think we need to make sure that it is a technical area, and part of why it has not come to this light for so long has been that technical area seemed out of reach. And we know it is not, and this group is testament to that. But I think that needs to maybe be seen a little bit more. And then I think as this process goes on later, we'll have to just really make sure that we crosswalk this with all of the other really important resources that have had whole journeys and methodologies behind them to come to light. And, in terms of toolkits, frameworks, efforts, movements, to make sure that we are entering the ecosystem in a smart and strategic and supportive way, and not in any way kind of adding confusion or noise as an unintended consequence. So, but thank you so much.
Thank you, Hema. Thank you very much for your thoughts and contributions, and summarizing some of the things that are already coming through in the chat box. The idea of putting this slide up is not that it is something that is the end product. This is the beginning of where we want to go. And so what we are suggesting here is that initiating that conversation. But even to initiate that conversation, we wanted to first have this consultation with countries and listen to what the countries are doing, what are they have been able to achieve, how have they done that, where do they see that there are gaps. And now with that background and the feedback that we are getting, we can get, this will not be one slide, this will be probably a few pages of document which will pull together all these and flush out each one of these, talk about some underlying principles like quality improvement, etc. For sure, those things will be part of the process. Before I go to specific comments from now others, because you can see even amongst ourselves, there is a lot more that comes to mind. And this has to be a process. It can't be something that starts with this consultation and stops. This is a process that has to continue. And my friend Louis, I will always remember of I really liked Rebecca Khortum's today. Rebecca made a thing saying that this equipment saves lives if it is used. Similarly, I would say any guidance, any guidelines, any document is useful only if it is actioned, if there is action in countries with that document as it moves forward. So we have to make it practical and document and actionable. So I'll come to individual comments. I will just try to go through 2 more slides to tell you about the next steps in the process, and then I will give about, we are 10 minutes over time. I'll still give maybe 5 minutes or 10 minutes for discussion. But I really encourage you to keep writing in the chat box, because as I said, this is the process, this is the beginning. We want to take everything you say into consideration and consult with the countries and partners as we go along to make this into a generic model, as Lily said, that can be used and adapted in countries. So next slide, please. And then I'll come back to people. Please do raise your hands. I will come back to all of you in a moment. There was some slides that Shoma sent you. Yes. There are two more slides that I want to say, which are other conclusions other than what we have just said, which reflect our commitment to this area. This is that slide. So all countries should strive to have at least one functional level 2 unit, which is basically what we have all signed up to under ENAP. But then in making these units functional, all partners should support countries in a coordinated manner under the ENAP umbrella and government leadership. So it is something that we are trying to see if we can all agree on these 4 bullet points. Further, all countries should adapt I can't read anymore. Adapt or adopt the WHO quality standards or SICN small newborn care standards as the basis for scaling up the SNCUs. And finally, incorporate innovations and new learnings from research as we go along into the special newborn care units, their design, etc., when building new hospitals or renovating old ones. So we thought that these could be 4 additional interventions that we could come up with as we go along from this consultation. If people would agree, I would also like you to write in chat box if this is something you would all agree on. We will also share with you these conclusions for you to add, subtract, or say you agree or not. The last slide that I want to put on the table is the next steps. So WHO and UNICEF in collaboration with other ENAP partners and all the countries, that's the most important, that the countries not only the ones present here, but beyond, will develop an implementation guidance that defines the models of care, how to scale up inpatient care in a practical and doable way, using all the information that we have so far collected and captured, and all the experiences that we've had, wonderful experiences, including, for example, what we have learned from the countries, what we are learning from newer projects like NEST. Continue to build commitment of national governments for scale up of SNCUs, mobilize resources from both domestic and external resources, and coordinated support, providing coordinated support for action to the countries from all partners. So this is what we have. Now I'm going to go back to the slide which had the 10 components. I have a few hands that I see. You can even stop sharing now. I think people have seen this enough. But if you want to write in the chat box, if you agree with the other conclusions, the commitment conclusions, that we would like to do that, we all partners would like to come together under this to be able to really support countries to do that, that would be great as well. But I see a few hands and would be good to hear from those two people at least. There were raised hands. Rajesh, I think you have already spoken. Is it a new hand, or I will come back to it? Fatima?
Legacy, sir.
Fatima first, and then Azamta.
Thank you so much, Rajiv, and can't praise enough all the work which had gone into this process and the learning which we all had. Thank you so much to all the organizers. Mine was just a humble request. As we know that, globally, it's when we have these global guidelines, at times you can translate them at local level. At times, they are too generic to be translated in a local level. So my humble request was, if it could be possible this time, a little bit bottom-up approach, which you have already initiated here with this consultation, and then moving forward, if regions can work with their countries, because all of us have different contexts. Like in many countries in our region, our essential newborn care is not even up to mark. So many a times we get referrals which are not even necessary to be in newborn care units, and we have now newborn care units which are overwhelmed with so many babies with very less staff there. So we in each of our regional contexts, we may need to also look into our basics as well while we are in strengthening our sick and small newborn care. So we do not want to drop the ball on this other area, because no matter how much this investment has gone into it, but this is the fact of the matter that essential newborn care is still poor. So this is just my humble request, that if there could be a regional level, we do our own regional consultation with our countries, and then we propose, and then it could, go into the larger global level of document. Over.
Thank you very much. I think you're making very important point. This is only helpful if it is added on to the essential newborn care. And we didn't say that, but that doesn't mean that we are going to say this in isolation. But very good point. We'll keep it in mind that it is put in a way which is framed correctly. I have Fatmata, I had Azamta, Muruti, you have spoken already. Sorry, I didn't realize.
Oh, mine, I think I put mine in the box because I was thinking of data. We talk about quality of care being cross-cutting, and I think data should also be brought to be cross-cutting.
Perfect.
For everything, yeah.
No, that's extremely important. Thank you.
I agree with the rest, yeah.
Yeah. My only request to my colleagues, her, Olive, Karen, Teshome, Gagan, is that we just make sure we save the chat like gold. It is very, very, very important, right? So please make sure that we have it, and 2 or 3 people have saved it.
Yeah,
so
it's
let's
done.
never lose that. Thank you very much. Fatmata, last comment from Dr. Fatmata Sese. And then I will request Louis to close the meeting. Thank you.
Thank you so much, Rajiv and colleagues. This has been an excellent and rich discussion for the past few hours, listening to all of the contributions. I just want to say that from a nutrition point of view at UNICEF, we are fully committed to supporting this process. And we recently launched our nutrition strategy, which fully commit us to supporting optimal breastfeeding from birth up to 2 years, as well as other caring practices. So definitely the care and management of small and sick newborns is definitely at the heart of our strategy. So we continue to focus on providing comprehensive package of care, which includes KMC, zero separation, and the latter, which is also very important in our current context of COVID-19. And we will continue to work with all of you in alignment with the interventions we currently implementing, which include the baby-friendly hospital initiative, the MAMI approach, as well as the No Time to Waste. And we look forward to continuing being part of this discussion and leveraging on the multiple expertise and experiences we have here today to also bring nutrition strongly at the forefront of this initiative and intervention. So thank you very much all for your contributions and efforts today.
Thank you, and thank you again, all of you. Over to Louis to close the meeting. Thank all the participants, etc., from behalf of WHO and UNICEF. Over to you, Louis. Thanks.
Okay. I want to propose 3 letters to close the meeting in the spirit of our collaboration. First is C, countries, and the B, second is B, the basics, systems, and the A is actions that we'll take together. So CBA, countries, basics, and the actions. I want to thank all of you, WHO colleagues and my colleagues in UNICEF, and all of you from the countries, our government counterparts, your leadership, your commitment at the front line, and all the partners. Thank you for your support. We look forward to work with you to take our actions forward.